Arlene Lemus, the CEO of PAVE Prevention, Proactive Anti-Violence Education. And we are involved in our next episode of Disrupting the Dominoes. Now, remember, disrupting the dominoes, that's disrupting the dominoes of violence. And that's from microaggression to full-blown physical events, where we have conversations on what can make situations better. How can we make substantial change in corporations and organizations? And we have an incredible guest today. I'm super excited. I've enjoyed every conversation that I've had with this gentleman, and I think you are going to have a fantastic time listening to him, his viewpoints, and his experience. Really, it is a vast commitment. So our next guest has a lifetime of advocacy and work for creating safer workplaces in the healthcare sector, not only so that it improves patient safety, but it improves employee safety as well, and has been really looking at things in a lens that PAVE hopes to look through as well, in how can we improve bottom lines? Why is this approach, why are we letting this happen? Not only for the horrific things that are happening, we've got to stop it, but we can improve the bottom line for our facilities if we get better at those things. So our next guest, incredible life of advocacy and support for healthier workplaces in the healthcare sector. He has been a professor at, the list is long here, USC, GW, University of Wisconsin, Wayne State, very impactful, a American College of Healthcare Executives Fellow. I mean, this man has had such an impact on creating a safer place in the healthcare world. I'm just so happy and proud to introduce our next guest, Arthur Shorr. Welcome to Disrupting the Dominoes.
Arlene, thank you. It's a privilege and a pleasure to be here.
So, I mean, I know that I touched on just a little bit of your illustrious career and the impact that you've had. If you'd like to share a little bit more with our listeners and our viewers about, the road that you've taken and where you feel you've been impactful.
Well, I actually started my professional career earning an MBA in hospital and healthcare administration from the George Washington University in 1970. And I was very, very, very fortunate because in those days, in order to earn a degree, one had to spend a year in an administrative residency under the tutelage of a CEO in an acute care hospital, if you wanted to be in acute care administration. And I ended up going to Central City, Detroit, a year after the horrific race riots in Detroit in 1970. I went there in 1969, actually. And my mentors were an MD CEO and a chief operating officer who's of course graduate in healthcare administration. And they took an accounting major, which is what my background was at that time, and converted me into a patient-centric, nursing-centric hospital administrator. And they set up a program that ultimately lasted 8 years. And the program, the learning experience, was a Malcolm Gladwell actual textbook experience, because I've been in the industry now over 50 years. And I've never had an experience after my first 8 years at Hutzel Hospital in the Detroit Medical Center that I didn't have in that first 8 years. If you can imagine a level of training, 10,000 hours easily occurred within that time frame. And I became a patient-centric hospital administrator. I was encouraged to teach. I was encouraged to write and contribute to the industry. And my focus was the patient at the bedside, and recognizing what many of, unfortunately, my colleagues today don't recognize, that the locus of the healthcare industry, or in the hospital industry, is the bedside. It's not the C-suite. It's not the executive offices. It's not the service line. It's not the loading dock. It's the patient bedside. And I basically spent my entire life involved with that basic priority. I've worked in 3 institutions, 3 healthcare facilities, Hutzel Hospital and the Detroit Medical Center for 8 years, the Mount Sinai Medical Center in Milwaukee, Wisconsin, where I was the administrator and chief operating officer, if you can imagine, at age 31, and acting CEO for a year. And my final hospital experience was what was called in the old days in Disneyland an e-ticket ride, the best experience one could possibly have in an amusement park. I was the senior vice president for administration and chief operating officer at Cedars-Sinai Medical Center in Los Angeles, California. Arguably the greatest operational job that one could have. But all the time that I was involved in my full-time job, I was also addicted to teaching and mentoring and recognizing that the people who invested in me required me to invest and pay it forward with others. And it became a disease, so to speak, a disease of pleasure. And I taught at the universities that you did for the self-satisfaction and also to help develop the next generation of healthcare executives along the philosophy of patient centricity, that it's really about managing the patient. And if you talk about managing the patient, then the real question becomes, what's the most significant priority? And the answer is patient safety.
Right.
Patient safety.
So I'll share with you that I had always been looking at PAVE's impact in creating a safer workplace and a safer environment while at work, especially through the healthcare lens of, giving our nurses a skill set, giving our administrators a skill set, to set a boundary or defend themselves or de-escalate situations. I had always thought of that. So when we had our first discussion, I was so intrigued with the idea on, okay, how could our training, how could our programming also create a culture that would keep patients safe? So because of the statistics that you were sharing with me, they were incredible. So please share more about what hospitals are struggling with, the unfortunate black eye that the hospitals are dealing with right now, that you shared with me about this patient assaults and patients not being safety while in these places where they're supposed to be safe.
Well, if you don't mind, let me take a step back and
Sure.
put it in a framework. Think about what a patient does when they come to the hospital. They basically give up their civil rights.
Yeah.
By choice. They say to us, and we say to them, you come to our facility, and we will do everything within modern medical science and technology to provide you the best available care, treatment, and diagnosis to maximize your situation. But in return, in order for us to do that, you have to agree to follow our direction. We're going to tell you what to wear, when you can get in and out of bed, when you can use the toilet facilities, what you can eat. We're going to take away your medications. If you have false teeth, more than likely we'll take those away temporarily. I will tell you when you can walk. And in return, we commit to you to keep you safe, first and foremost, and then provide to you that which we can to maximize your human condition. That's the moral contract that's been lost. That's been lost. And because it's been lost, patient safety is not considered a priority in our world. And unfortunately today, since a good deal of the work I do is testifying as an advocate about hospitals' compliance with standards of care, the administrative standards of care, today we're unfortunately involved in a pandemic of sexual assault cases on patients. That's hospital violence. We have all too often cases involving employee violence. Employees, there's a level of violence going on that just boggles the mind. I mean, if and when I am right about patient safety being the fundamental agenda, the question becomes, how can we be violating the core agenda of what we're supposed to be doing? And that's where we are today for a whole host of very complex reasons that range from political to financial to academic to, it's a wide number of subsets that result in patient safety not being priority number one.
Wow. So Arthur, I'm just always, this is a side note and something that we're discussing right now, but I am amazed at how there are so many similarities across sectors and how many similarities to my pathway to violence prevention when I speak to our guests. You know, you're talking about patients losing their civil rights when they come in or giving up their civil rights. You know, it's much like an athlete who joins a national program who's, you know, done everything correct, and now they've been selected and anointed as an athlete that can come to the Olympic Training Center and become, you know, a funded athlete. So I had never thought of it as an athlete accepting that and signing that contract between themselves and the national governing body to represent this country at an elite level as being something that might give up your civil rights. But in a sense, those athletes did that, right? Because they too are told what to wear every day and what team outfit they're wearing and when they should report to training, and in many cases, what they can eat and what they can't eat, and when they should go to bed, all of course for a dream, right? But it seems that that dynamic, whenever that dynamic comes into play, there's a chance for someone to abuse their position. And that's, how do we stop that from happening? And how do we give the people walking into that situation? How do we give a patient, or how do we give the people around the patient? How do we give the athlete or the people around the athlete the skill set to keep them safe and to keep their culture safe?
Well,
It's the same.
Let me answer the question two different ways. Let me answer the question from the patient's perspective, from behind the prism of the eyeballs of the patient. And then let me answer the question from the healthcare industry perspective. We tell everyone in our family today, and I'm almost embarrassed to tell you this, but you know, I'm not gonna pull any punches with you. We tell everyone in our orbit that we care about, if you are indeed hospitalized, or if anybody is hospitalized, please make sure there's a representative at the bedside. Whether it's family member, if you can do it that way, or if you can't, you have to hire someone to be at the bedside. And part of the issue is patient safety. And part of the issue is the deficits in our industry today. And the best example I can give you is grandma's in the hospital for some care, and it's now 3 o'clock in the morning. And let's assume grandma's perfectly lucid and she needs the restroom. And she rings the bell as she was instructed, and the staff can't respond for whatever reason. And let's assume a legitimate reason that the staff can't respond. They're involved in issues that are holding them away. Now, grandma's lucid. She has some choices to make. Does she soil the bed? Or does she go over the rail and try to get to the bathroom? If she goes over the rail, the chances of her falling and breaking a hip, which is a trajectory that you don't want to get onto, increases exponentially. Now, if there's someone sitting at the bedside, they can go to the nursing station and say, look, my grandma is really in trouble. She needs the bathroom. I can't assist her. Can you have someone come? Or what? So there's an example of something nothing to do with patient safety. But with someone at the bedside, by definition, the chances of there being any kind of negative physical attack or a sexual attack is eliminated. It's absolutely eliminated. Now, it's a sad commentary to have to say that's what I as a professional tell my family, but that is today's reality. Now, from a healthcare perspective, from an industry perspective, looking at it from above, the statistics of the American College of Healthcare Executives, when they poll when they poll chief executive officers, results in patient safety never getting above number 5. It never gets above number 5. There are other issues that CEOs have. Now, in any organization that's effective, where there's effective leadership, you would assume that the role and the priorities of the CEO drive the organization. So now you have an organization where patient safety is not number 1. And now you reconcile that with the moral contract that we've made to each individual when they cross our threshold and what our commitment is supposed to be. You have a gap into which violence falls.
Right. Yeah, it still is just mind-boggling to me how we haven't got to a place, I guess as a society, definitely as a country, we haven't gotten to the place where creating safe places is not important, is not a top priority. Keeping the idea that being able to live in a safe atmosphere isn't a top priority.
Our society is what it is. It's an evolving social experiment. Now that I'm long in the tooth and in my 70s, my late 70s, I look back at the trajectory of life experiences, and the world keeps evolving, and it has elements of complication that are beyond my pay grade to really understand. But
right.
It's a very complicated world we live in.
So, Arthur, you have written extensively, you've been published extensively, you've been a presenter all over the world, and some of the things that you've written and presented about, I'd like to discuss and hear, a little bit more about them. Part of what I think the strength and the beauty of what PAVE is trying to do is the creation of our assessments, where we can really show, this is your employee experience score around violence workplace and the culture of violence in the workplace. Okay, now post-programming, 6 months, 9 months, a year after, we've come back with the same survey. We see this improvement, this area of improvement. I'm not finding that the healthcare sector, when imparting violence prevention or workplace violence training, is doing any of that. They're not coming back and seeing what works. They're just throwing a whole lot of money at the problem with with not any accountability or evaluation on if it's working. So one of the articles that I saw that you published was the role of the CEO in maximizing patient safety and hospital safety. Can you share a little bit more about that article and what were your points on why this was important? Because we believe this has to be, a top-down and bottom-up kind of approach. So I'd love to hear where you saw the CEO fitting in on that.
Okay, but I'm going to come at it from a very strange place.
Go for it.
I'm going to come at that article was written a number of years ago, and it's still relevant today. Thank you for bringing it up. But I recently taught a class at George Washington University to second-year students that were ready to embark on their careers. And I started the class with something a little unusual. It was a Zoom class, so I didn't have the privilege of looking my students in the eye, but I did the best I could. I said, look, I'm going to ask you a question, and I don't want you to think about this answer. I want you to react to the question instinctively. You have 3 or 4 seconds to respond. And the question was simply this: second-year graduate students, 95% of whom were working in healthcare facilities to earn their tuition, and said, today, how many of you are comfortable walking onto a nursing station? By a show of hands. 30% of the hands went up. 65, 70% of the hands did not go up. Now, why is that important? Because it goes to this seminal question of who tomorrow's leaders are. If they are not comfortable on a nursing station it sets the groundwork for not caring about nursing-centric, patient-centric priorities. And if you don't set nursing-centric, patient-centric priorities early on in your career, as I was very fortunate to have happen to me, and you now evolve into becoming a CEO, and you now recognize that patient safety doesn't get above number 5 in the professional surveys, you begin to understand the correlation between the lack of education priority and the reality of how it translates years later when individuals who are not sensitive to patient safety, that are not sensitive to nursing-centric, patient-centric agendas, now are in leadership positions. It's easy to get involved in finance. It's easy to get involved in mergers and acquisitions. It's easy to get involved in a wide variety of issues that will consume you totally. And, oh, someone else will deal with that. That's my chief operating officer's job. So therein lies the framework of how it could be that patient safety is not a priority today. So now let's talk about it from the positive perspective. What is the role of the CEO? The role of the CEO is to manage the culture of the organization. Simply put, manage the culture of the organization. And how do you do it? Let's assume we have a patient-centric, nursing-centric CEO. What would that person be doing that his colleagues or her colleagues would not be doing? They would be making rounds on the unit and being in the patient environment with the caregivers, being accessible to the caregivers, making rounds. That person would make sure that the orientation program had an emphasis on patient care and patient safety, would have a very senior person in the organization at those orientation meetings to emphasize the point. Right. Would make sure that the house organ had a recurring article and presentation and feature about patient safety, whether it's the employee of the month who went out of their way to do something related to that, or an issue of how to do something related to, in other words, it's got to be something that you promote all the time in every dimension of the environment, starting with personal leadership on the floors, making rounds. And let me give you an example of that. When I came to Cedars, an organization that was highly sensitive to political hierarchy, and I decided to begin to do this, my staff was very uncomfortable. The entourage was very, very uncomfortable. I said, come on, let's go, guys, we're going. And we started making rounds on the floor. And at first, the staff looked at us, who the hell are these people? Why are they here? Did we do something wrong? On and on and on and on. And eventually, it took maybe 3 or 4 cycles, and finally, we became approachable. Imagine, we became approachable. And eventually, we were able to solicit input from staff. And we made rounds on all 3 shifts. And at first on the night shift, for example, in the old days when we had 3 shifts, the issue was, you promised to escort me to my car after work and it's not happening. The HR department's not open. You know, the cafeteria is not serving good food for us in the midnight shift. 4 or 5 cycles later, it was about, hey, we need more staff. Hey, we need more wheelchairs. And the issues evolved from issues that dealt with patient care and patient safety. And it requires that kind of leadership.
Yeah. I mean, that's one of the proposals in our training, the comprehensive approach to our training is this, post-evaluation, post-assessment, post-training, this roundtable sit down with all stakeholders, not just a meeting with the C-suite individuals and then a meeting with the nurses. We'll use the healthcare sector as an example, but representation from all the sectors within the hospital that we're administering programming. Our client, who is our client, this round table of, hey, this is some of the information we received out of our assessment. These are some of the things we've noticed and information we've collected during our training. Let's discuss this, guys. Let's chime in, everybody at the table here, and let's have a real discussion. If we're going to make substantial cultural change, if we're going to really change the culture, these are the conversations we need to have. So I definitely appreciate that approach, Arthur.
Well, let me give you an anecdote, a very personal anecdote. For many years, my dad just did not understand hospital administration. He understood my nursing cousin. He understood my sister, the dietitian. He understood the doctors in our family. But what do you do? And you know, he really never got it. And finally, when we got to Cedars, I always toured him through the hospitals. Well, when we got to Cedars, I took him on a tour of the facility because it's an extraordinary physical plant and whatever. We get back to my office 2 hours later, and my dad says to me, "You know what? Now I understand what you do." I said, "Really? It's only 12 years later. What do you mean you understand what I do?" He said, "Look, we walked around this facility for 2 hours, and we met doctors, we met nurses, we met patients, we met staff. We met every kind of individual in the place, and they knew you as Arthur. Now, if
That's
they
awesome.
know you as Arthur, that tells me you're the boss. You're the boss. You're leading this organization." And therein lies the greatest compliment my father ever gave me about
Yeah.
work.
Yeah,
took
that's
12
awesome.
years, but it's a very, very real story, because it goes to the question of leadership.
Right.
And until you have that intimacy with your staff and short circuit the hierarchy of the pyramid that is hospital organization, you really can't have an impact as strong as you can if you have that intimacy with your caregivers.
Yeah. I mean, I see a lot of similarities with coaching and a leadership position, a CEO position on where you're at. If you're leading your team, I'm sure that Dr. Pete Margella, who you met within our organization, and his military background, sees it the same way. Leadership is leadership, you know, and good leadership can make or break you. And I think that as we move into a world, I hope, of post-pandemic, I think the need for a different approach to leadership is going to be more important than ever.
No question about it.
So back to a couple of the other articles and presentations that I found in my research after our discussions. One of the things, again, you're really heavy on accountability. And I think that if I remember correctly, there was one that you wrote on accountability after the trauma birth case that you were involved with, and then also accountability when it came to institutional negligence. So could you talk a little bit about that and how you see that in the violence prevention world as well?
It's the bottom line. It's the bottom line. And again, if I can digress and come back to it, standing back and looking at our society, whether it's Enron or whether it's the stock market or whether it's the mass shootings or if it's politics, the common denominator in what I would think would be a generic root cause analysis is the lack of holding individuals accountable. And if you don't hold individuals accountable, or if you make the penalty an abstraction, like a financial compensation for infliction of a negligence that results in injury or death or pain and suffering, you're diluting the issue, and you're ducking the issue of accountability. And therein lies to me, the societal defect. It's not only in our industry, it's across the board.
Right.
You don't have to go any further than politics when you hear, and I'm not going to get into the social issues of the day, but when you hear statistics that say 75-80% of the people polled in the United States want us to go in direction A, and our politicians are going in direction minus A, where is the accountability? And it doesn't matter what the issue is. It doesn't, you just stop to think of the concept that represents, the lack of accountability at the political level, the lack of accountability at the societal level, at the criminal level is probably the only place something happens. But the definition of criminality is very, very narrow, very, very narrow. And yet, when in my world, when a negligence occurs in a hospital, sometimes it is so egregious. And I'm not an attorney, so I can't speak from a legal point of view, but it looks like a crime when it's willful and egregious and knowingly wrong, and it's done. To me, that's a crime, and it goes again to the lack of accountability that all too often I see, and that's when I serve as an expert witness on behalf of a plaintiff. It really goes to the question of asking my colleagues, do you know what the standard is? Did you make sure that standard was complied with in this instance? And if it isn't, or if it wasn't, and the injury or the death or the pain and suffering that occurred is legitimate, where's the accountability? Don't talk to me about the financial reward or award. Talk to me about accountability. And I never hear accountability.
Yeah, I mean, I think it's so true. I think people who look from the outside at perhaps a group of athletes that come forward and share their story about abuse or assault, I think they think, oh, they're just looking for this paycheck, or they're looking for this monetary being supported with money. But that's not it. The whole case could have been avoided going to a situation where there's a lawsuit filed. If someone would have just said, hey, I heard you, I'm sorry that happened, we're going to fire that coach, or this coach is never, ever going to coach again. But that accountability is not happening. And then it leads to the lawsuit. It leads to the press. It leads to, everything else that comes along with it. But really, I hate using the word victim, or, maybe we'll use survivor. That survivor is just looking for someone to acknowledge what happened. Acknowledge that it happened. Be accountable for what happened to them, and then change it so it doesn't happen to someone else. I think that's all really they're looking for.
We actually have a very positive such situation in the industry. Back, I think, in the 70s or maybe the 80s, a VA hospital, I think it was the VA hospital in Kentucky, did a survey to answer the question, why do people sue hospitals? And the answer came up just as you said. It's not about the award. It's about the rage of not being told the truth and not accepting responsibility. So the VA adopted a program called Sorry Works. And what happened, and there was a CEO at the university, at the hospital in Minnesota, that was a front page Modern Healthcare article many, many years ago, adopted the concept of Sorry Works. And what those people did was, if and when there was an injury to a patient or a claim of wrongful activity, and the investigation demonstrated the truth of that, the CEO went and sat with the parents and accepted responsibility, said, look, we'll deal with the compensation issues. That's not why I'm here. I'm here to tell you, I understand what happened. I understand that we have to make sure it never happens again. And I want you to know we got it wrong, all other things being equal. And if I can take you back to Cedars-Sinai Medical Center, if you remember the event many years ago with the twin Dennis Quaid's grandchildren, a set of twins that were given the wrong medication and almost died. The next day, a colleague of mine, the vice president for medical affairs, came on television and indicated, we made a mistake. We got it wrong. And basically, The family recognized that the issue wasn't with Cedars per se, even though a nurse made the error. It had to do with the labeling of the medication. And it took the issue to its real root cause, the manufacturer that was not labeling dosages correctly that allowed that kind of an error, increased the probabilities of that error. So we do have examples of where sorry works. Unfortunately, it's not the pervasive, it's not the default position. It happens in highly enlightened institutions with highly enlightened executives and colleagues.
It's interesting. We had a conversation, two conversations with guests. One is Julie Harmon and one is Nick Matone. And both of them brought up similar situations. Julie brought up one of my favorite quotes now, and that is, we need to normalize mistakes and really have conversations around intent. So, I mean, I thought that was a fantastic quote during the show. And then Nick Matone, who is in the hospitality sector, he's kind of a guru fixer within the hospitality sector. And he said, they created something that they called enlightened hospitality. And it was really the concepts that you're talking about, is just, being able to say you're sorry. Chefs blow up in the kitchen all the time. It's a high pressured situation. Things get, wow, what are you doing? How could you do that? And, but it's circling back at the end of the shift and saying, man, I lost my cool. I'm sorry about that. Hey, let me walk you through how that plate should have been properly plated. And this way, we'll get it right next time. So that enlightened approach, as you just used, to me, it's not rocket science. But if the culture doesn't allow people to come forward and doesn't create a trust built situation, how are people going to be okay with saying, I'm sorry? I mean, it really is a holistic approach if we're going to make those changes.
Agree.
Yeah. So in one of our conversations, you said something, and I'm trying to remember your quote exactly, but you said something to the extent of, when there are mistakes made or there are wrongful suits being filed, comes back to three things: hiring, training, and supervision. And I thought, this is exactly the approach we're looking at with our programming, right? We feel that our assessments can be some indicators on how you're hiring people and the type of people you want to hire. We feel that our training is instrumental to creating better communication, employee well-being, trust in the organization and trust in their fellow employees. And of course, creating powerful and meaningful relationships with supervision and the people that they're supervising. So please share a little bit about that comment that you made to me and why that you feel those three categories are so important.
When I look at the cases we're involved in now, specifically to sexual assault that are perpetrated by hospital employees, or in some instances, physicians, credentialing and hiring are really parallel tracks of activity. Those are the precursor activities that occur that go to the question: will that individual be allowed on our campus to do that which they are trained to do, whether it's a nurse or a nurse aide or a physician? If it's a physician, it goes through a very complex credentialing process. If it's an employee, it goes through a hiring process. We see a common mistake occurring that occurs in just about every instance of sexual assault in a hospital. Sexual assaults don't start at age 35 or 37 or 40, if you will. It's a syndrome that exists in a human being, and it may be clinical, it may be something far beyond my ability to tell you what it is, but it doesn't start with the incident at hand. when we look at the hiring process, one of the requirements of the standards of care is that every prior employer be queried. And even though there are very strict limitations on the questions we can ask, and we usually are limited to hire date, fire date, job title, and salary, there's one additional question that we are allowed to ask. That is the seminal question. Is this individual eligible for rehire? And if the answer is yes, that tells you something about their tenure. If the answer is no, why would you hire someone that is not eligible for rehire in a previous employment?
Right.
And the same parallel exists on the physician side. Every application to the medical staff requires references from individuals who know that person intimately, professionally. Every institution that individual has been at and prior to coming here has to be questioned along the same line. Is the person eligible to recredential, to get privileges again? And in cases where sexual predators are allowed on the campus, almost invariably, those were failures of the administrative process. Hiring somebody without checking that, which if only you did one thing, that person would not be employed in your facility. And if everybody did that thing, that individual would not be involved in patient care any place. So there are some other factors that go into it. People with very short employment records, if you will, multiplied by this factor, are almost predictors of sexual violence in your facility.
Well,
it's that simple. Arlene,
right.
it's this, you hit the right words. It's not rocket science.
Yeah.
That's simple. Now, let's take it to the question of accountability. Let's assume it didn't happen. What happens to the people who are supposed to do that? What happens to that department head? What happens in the organization that doesn't find out that the issue is a defect in a process, rather than telling the patient's family, oh, she was under medication and she's probably hallucinating? I mean, therein lies the dynamic of sorry works or not, and what the fundamental issue of day-to-day operations are when it's done correctly versus when it's done incorrectly.
So you have this hospital that, for whatever reason, stands up and says, you know what, we're not comfortable renewing your contract here. Let's say it is surrounded about maybe some accusations of a sexual assault or predatory behavior. But that person is a rock star at what they do, right? They're very charismatic. So another hospital picks them up. Are those the type of things that are happening, or it's not? Because that's what's happening in the sporting world, right? You have this successful coach, charismatic coach, has a career with some, some merit.
We know those stories. Yeah, yeah. We don't need rock star. Take rock star out of the equation. Replace rock star with a shortage of nurses. Replace rock stars with a shortage of physicians in a given area. We don't need rock stars. We're talking about regular people. It's not about the gymnastics coach. It's not about the university of physician that are the rock stars. I'm talking about bread and butter, day-to-day tasking. And if there was a consistency, that person would not be involved in access to patients unfettered. But now let's go someplace else. Let's go to a different dimension. We do have a shortage of nurses. We do have a shortage of doctors. How can we mitigate the circumstances? I haven't done the survey, and if I was young enough, I would probably go ahead and do it, or maybe you can commission the person to do it and answer the question: how many hospitals and how many nursing homes, when they admit a patient to the hospital or the facility, and when they transfer that patient from unit to unit and they redo a history and physical every single time, which is our standard, ask the question, would you prefer to have a chaperone if the issue is is a physically sensitive area? Yes or no? We don't ask that question. What if that became protocol?
Yeah,
And now every patient is asked that question. My prediction is 90% of the patients,
we'll
and I'm
say yeah.
using myself as an example, so I don't need a chaperone, but 10% of the patients would say yes. That would make me more comfortable. Now, let's assume somehow we have a predator in the environment. Now, let's assume that predator can't possibly be at the bedside alone.
Right.
Therein
Well,
lies
I
a
promise you.
very simple solution that is so
Yep.
complicated to implement that I don't think I'll see it in my lifetime.
Well, I promise you, when we're working within the healthcare sector, we will make that recommendation. If you're really interested in creating safer work environments and a safer experience for your clients / patients, this is our recommendation that this be on the questionnaire. I think it's a no-brainer.
Here's how simple it is. Every time you have gone to see a physician, either in a private office or in the hospital, and the staff prepares you for that, here's one question you've been asked every single time. Tell me what medications you're on right today.
Yep.
And you go A, B, C, D, E, F, G, and you answer the question. Now imagine if the next question was, would you prefer to have a chaperone if it was a sensitive issue? That's how complicated the change is. This is not rocket science. Add this into the protocol. And lo and behold, I would predict that we would have an impact.
Yeah, definitely. Something so simple, but we'll see. We're going to make some change. Arthur. I promise.
Okay.
So you are one of our featured speakers within the healthcare sector at the PAVE Summit 2022. And that is a summit. We were specific not to make it a conference, to make it a summit, because we wanted high quality individuals to be a participant who wanted a voice at the table, who wanted a seat at the table when discussing solutions to reducing violence in the workplace. So we're focusing on 3 sectors and then some fringe sectors as well. We're focusing on the healthcare sector, we're focusing on the hospitality sector, and the emergency preparedness sector. And then we will also have representatives from sport, because that's how I got here. And you are a part of our summit. You're our guest, one of our guest speakers. What are you thinking about the summit? What do you hope comes out of this summit?
I would hope that my experience impacts people who are force multipliers, people who can absorb the validity of the arguments if they believe what I'm saying, and say, you know what, how do I apply that in my world? How do I take that message and bring that forward in a way that could have an impact? So if I can influence 2 people to be thinking about what I'm talking about as problems and as solutions, then I've achieved my success in that meeting.
Right. Awesome. Well, we're super excited about having you a part of it and, starting these conversations. It's amazing to me that these conversations have not been started, and then having the discussion of intersectionality and crossover from other sectors that we know are dealing with the same thing. What's working for you? Oh, maybe we can bring that from, the hospitality sector into the healthcare sector. Well, what's working over here? Let's bring that into the hospitality sector. I think that these discussions are going to be meaningful. To me, they're simple, but I think they're going to be incredibly meaningful when we have them.
Let's go back to your world for a minute. Let's assume we had an athlete that after an examination with a physician, a gymnastics athlete, felt uncomfortable. And what if she was empowered to say to her coach, you know what, I would like to have a chaperone, as much to protect Dr. Jones as to protect me, because if that's okay. And now that became the protocol of that training program. How simple is that?
Yeah.
If it was
Well,
initiated by the athlete who felt uncomfortable after one encounter, there would not be 47 encounters, and that person would be telling her colleagues in the locker room, hey, girls, you know what? If you want a chaperone, all you gotta do is
is
ask
that?
me.
Yep.
So
Yeah. Well,
there's the force multiplier of a recommendation that I can make in my world with patients who are vulnerable to athletes.
right. And I mean, and then an athlete going home and sharing the story with a family member, and then the family member going and saying, oh, when I go to see my dentist, I'm going to make sure while I'm under that I have someone there with me. I mean, it is going to spread exponentially. I mean, it really is.
That's why it's called force multiplier.
Yes. Yes.
We're only one, the problem is we can only do certain limiting factors as one person. But if we can energize people to pick up the baton, if you will, and keep running down the track, next thing you know, you have an exponential number of people running down the track.
Yep. Yep. So before I ask my last question, it's a question I ask every guest. I would like to give you the opportunity to share anything about what you're doing. What are you working on? Is there anything you'd like to share with our listeners and our viewers?
The only thing I'm working on, and I don't know how successful I'm going to be, is I'm hoping to approach my professional society to develop a career track of very senior people, experienced hospital executives over the age of 55, let's say, and develop a training program for expert witnesses to articulate the standards of care that are required of us. Because the more people who articulate the standards, and in many ways, there are very few of us that are willing to stand up and articulate those standards in the context of a legal conflict. There's no way to drive accountability unless and until you get the voices out there that say, this is the standard, this is what happened, this is right, this is not right. And we accept responsibility for mistakes. We activate sorry works at a higher level of activity, and that has to come through the voices of advocates for the standards of care. So if I am successful, I'll be able to create a new generation of testifying experts. If my industry says to me, thank you very much, have a nice day, it will be what it will be.
Well, my gut tells me that you'll be able to usher in this new
I hope so.
new
I
profession.
hope so. I hope so, because it goes back to the basic agenda of what our responsibility is to every human being that crosses our threshold. First and foremost, safety. Secondly, applying every available medical technology and resource to better their condition. But you can't have B without A. You just can't have B without A, especially if you abuse somebody in the process.
Right. Yeah. And I think that I heard through some whispers on the wind or something that you were working on a book, that you were publishing your life story. Is this true?
It's done. Yeah. I actually spent 2 years writing From Brooklyn to Beverly Hills, Capturing the American Dream, a first generation success story of how someone like myself from a family of immigrants was able to emerge from the ghetto of Brooklyn, New York, and ultimately achieve a level of competence and to some degree be able to influence the delivery of healthcare in the United States. It was a privilege to, in retrospect, looking in the rearview mirror of writing it. I started writing it for my grandkids, who really only know me as grandpa and an authority figure, and I wanted them to understand how things evolve over time, because all too often young people can only see tomorrow. They can't see around the curves. We're not equipped as young people to do that. But if you read if you read the pathway of people in your world who you can relate to, hopefully that would be able to influence people. And I didn't realize it when I did it, but this book is really something that every first generation parent who throws themselves on the sacrificial barbed wires so that their children can get ahead and become professionals. That's the lifeblood of the American success, in my opinion. It's the immigrant and the children and the grandchildren of the immigrants who drive this country forward. And I'm not being political now. I'm being strategic, and I'm being practical. It's not about politics. It's about capturing the opportunity to achieve something and impact our society. And that's what we all that have been some degree, we were successful. That's what we have done individually and to some degree collectively.
Yeah, that's it's definitely what my grandparents did for my mom's generation. She's the first generation, one of 12. Her and her siblings make up 12. And I'm first generation on my dad's side. So it's definitely something what you're sharing comes to my heart. So I can't wait. I think I've been promised a copy, so I can't wait to read it.
Everybody else can get it on Amazon, but you're going to get yours in the mail.
Great, great. So my last question, Arthur, and then we'll wrap it up. If you were given the opportunity to have an audience of one person or one group that, man, if I sit down in front of this person or group, they can move our movement forward. They can make change, the change that we need, or contribute to change at a substantial level. Who would that be?
I don't know the answer to that question, but I would like to rephrase your question.
Okay, go for it.
Ask the question differently going forward, because I'm not sure there is any one person in a society of 330 million people who could achieve what you're talking about. But if you would ask the question slightly differently, Arthur, if you had the magic pen and you could write the direction of a process that people could embrace, what would that magic pen do? And the answer is, it would reach out, it would create an audio, it would create a video, it would create a documentation that would excite people to understand the problem, and to understand the problem at a human individual level, and then reconcile that by bringing their personal understanding into a societal level. So if it was a person who was an athlete, they would see it first and foremost in their own world and their own interactions, and then their team, and then their league, and then the broader environment. If it was the healthcare industry, it would be the patient, it would be the caregiver. And if enough people began to see the same thing, you would have a circumstance of collective weight. Now, all that being said, there's always going to be people who are on opposite sides of every issue. So the issue is creating a weight to drive an agenda forward, however quickly, however slowly, but have what would be momentum. So I would hope that the magic pen would be able to create enough energy through its ability to create communicative documents and educational forums and positive propaganda. Propaganda is not a bad word. It's the process of influencing people. So if we could create that through the magic pen, it would ultimately go to answer your question of how do we impact society.
Well, that's exciting, because most of the responses that I received have been kind of out there, wishful, Melinda Gates or Michelle Obama, or, kind of, I don't know. I mean, still important and powerful. And I understood why they made that statement. I love the fact that we should sit down with a room of teenagers and listen to them. But your presentation, I feel, is actually doable. I mean, we're going to be at that summit and we're going to be penning a document. We're going to have our magic pen. We're going to have 100 to 125 people rolling up their sleeves, sitting at the table, and that magic pen is going to be in our hands on what we want people to know after that summit. So I'm pretty excited about that, Arthur. I have not felt like I could make that happen when someone answered this question, but I'm feeling like I can make that happen.
I bet you can. I bet you
So,
can.
Arthur, this has been incredible. I've had a blast. I hope that, well, I know that our viewers and our listeners are going to appreciate just not only the wealth of knowledge that you have and the experiences that have formed you and that have impacted other people in the healthcare sector and beyond, but really it is very clear and evident just your heart and how you want to make this world a better place. It really is. That is what has stood out for me in the conversations that you and I have had. So this has been a wonderful conversation. Thank you for joining me.
Thank you very much for the privilege of joining you.
Okay, so I look forward to doing great things with you. To our viewers and our listeners, this has been another episode of Disrupting the Dominoes of Violence. I'm Marlene Lemus, CEO for PAVE Prevention. We'll see you on our next episode. Subscribe, check us out.